Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 541 of our pharmacotherapy series, which majors in bipolar disorder. The first case reads, TCR is a 25-year-old man, accompanied to the clinic by his wife, BAR. She called the clinic before bringing him in and reported much of the following information. TCR states that he was doing well until about 3 weeks ago, when he returned home from a crab fishing trip where he works for the winter months. Given the stress of the job, he borrowed some nerve pills from his fellow co-worker. Since then, TCR has been acting increasingly wild. He has been staying up later at night and often bursts into the bedroom at 2 or 3 a.m. and loudly awakens BAR. Sometimes, he presents her with expensive gifts, which they cannot afford. He often jumps on the bed and starts singing her love songs in a loud voice. BAR notes that TCR then almost always demands sex, after which he sleeps for 2 to 3 hours and then loudly gets up and leaves the house. During the last several weeks, he was noted to be driving his car recklessly and well beyond the speed limit. The police have pulled him over several times and given him multiple tickets for not only speeding, but for running red lights and passing on the double yellow lines. Last week, when his boss called to express concern about his behavior, TCR said he was quitting his job. He wrote an rambling, disorganized resignation note, which was at least 10 pages long, called an overnight air delivery service to send the note to his employer, who is located only 3 miles from his home, and then left the house before the driver arrived to pick it up. TCR returned several hours later with a brand new car and wearing an expensive new suit, red cowboy boots, and a bright green hat with a large feather. He told BAR that he had a new job, which was going to make him a millionaire. Last night, she found a large sum of money in his pants pocket when emptying the clothes hamper. He did not come home at all, but he called her at 4 a.m. to tell her to pack for Dallas, where he was going to become the new head coach of the professional football team. On arriving at the clinic, TCR insists, "I don't need no doc. I am supercalifragilistic." He then bursts into song. He is dressed flamboyantly but needs a shave and shower. He gives the examiner, a stranger, a bear hug and has trouble sitting still, listening, or allowing others to talk. His speech is pressured and loud. He often fails to complete sentences or communicate entire ideas, and he is rhyming and punning. His mood obviously is elevated, but he becomes increasingly irritable throughout the examination. He is oriented to person and place, but thinks it is tomorrow. Intelligence seems average. When asked to interpret a proverb, TCR becomes angry and throws a chair across the room. How is TCR's presentation consistent with the diagnosis of a manic episode? The hallmark of a manic episode is changes in mood, behavior, cognition, and perception. TCR demonstrates an elevated mood. He is exuberant and notes how great he feels. Nevertheless, manic patients often demonstrate lability in their mood, and they may become irritable and easily frustrated, especially when challenged. In this case, TCR becomes irritable and resentful when questioned by the examiner. His quick displays of anger further demonstrate the volatility of his mood. TCR displays behavior and speech typical of acute mania. He has a reduced need for sleep, behaves recklessly, and is overactive. His speech is pressured, loud, and full of rhymes and puns, and he sings to express his emotions and skips from topic to topic, reflecting a flight of ideas. Behavior often is characterized as being excessive. TCR dresses flamboyantly, hugs his examiner, writes an unnecessarily lengthy letter of resignation, seeks an overnight courier service for local delivery, and presents his wife with lavish gifts. Delusions are often present in acute mania and are grandiose or religious in nature and deal with inflated abilities, self-importance, wealth, or special missions in life. TCR makes unrealistic comments about his money-making schemes, his singing ability, and his position as the coach of a professional football team. Patients with acute mania are often disorganized and do not complete tasks. They tend to skip from idea to idea and scheme to scheme. In this case, TCR neglects his hygiene and neglects sending out his resignation letter. The next question reads, what factors make TCR vulnerable to the occurrence of a manic episode at this time? TCR is at the age at which his disorder would likely first manifest itself. In addition, manic episodes are often precipitated by psychosocial and recurring life stressor. Working long hours with reduced sleep may have served as a predisposing factor for the development of a manic episode. A variety of medications and clinical states can induce or precipitate manic episodes. The drugs that most commonly precipitate mania affect monoamine neurotransmitters, such as antidepressants and stimulants. Corticosteroids, anabolic steroids, isoniazid, levodopa, caffeine, and over-the-counter stimulants can induce or aggravate mania.